So, thanks a lot, Ashok, and let me say congratulations for the lovely book that you have been editor-in-chief of. And it's always great to be actually talking about all these lovely youngsters who have been doing a very good job. So let me tell you, with all these exciting things that has taken place in non-small cell lung cancer, in small cell lung cancer on today's date, actually, we are making progresses. We didn't have much of a progress at all. But in this period, we actually are moving through. And what's moved through with all this is basically our use of immunotherapy. So before I start, let me point out to you, very early small cell lung cancer surgery can be used and it may be curative. In patients who are actually having limited stage disease, the therapy, basically a standard of care today in good performance status, is concurrent CT-RT. And that is actually, we would also offer PCI to them after a reasonable period of time. In a metastatic disease, we would say that we would give 4 cycles of chemotherapy of etoposide-cisplatin or carboplatin. On today's date, adding immunotherapy is there. That's what I would be talking mainly. And any patient in good relative state, even in metastatic disease with good control, should receive PCI. Second-line therapy has been topotecan till date, but we'll see what's new right now as we move along. Extensive stage, as I said, is basically the use of platinum-based chemotherapies, platinum or etoposide, or platinum combined with irinotecan. The United States does not believe in irinotecan. Europe does not believe in irinotecan, but the Far East Asia does. And of course, there is a question of using PCI when the symptomatic brain metastasis is there, or when we want to prophylactically prevent it, we do use that after a patient is in good control. Thoracic RT only if you get a good control, basically. So use of etoposide and cisplatin was a main treatment base till 2019. 19 randomized trials, 4,000 patients, and what we did see was basically a benefit. Test of heterogeneity telling us that the benefit was round about 3 months when we use this as a chemotherapy. So when I look at the whole picture today, and I have started looking at it, we see that in between last year and this year, there has been majorly 5 new indications for using new drugs. The first line therapy has changed. Now we have the durvalumab and atezolizumab to be used. Second line, third line, I'll come back later. You can see on this slide with the FDA approval, I just wanted to keep it in mind to you all, is Lurbinectedin, which was just approved in the month of June, and Pembrolizumab also in the month of June for unresectable tumor with high mutational grades. So coming into the first line therapy of using durvalumab or atezolizumab, these were major trials, and if I look at it, there have been actually 5 major trials, of which 3 are randomized, 2 are non-randomized, and if you look across, whether we were using durvalumab or we were using atezolizumab, we had an improvement in progression-free survival. And the median overall survival also came around a year's time. Roughly anywhere between 45 to 50% patients were alive at the end of 12 months. Around 1/5, 20% were alive at the end of 2 years. And the hazard ratios, both for the performance, in the PFS and the overall survival, did show a 30% benefit with a good confidence interval. This is where we first had in 2019, 27 June, AstraZeneca saying that the CASPIAN trial actually was positive, so we could actually have a new data, and that's how we move forward. So I'll start first with IMpower 133. This is the atezolizumab trial, which is a combination of carboplatin with etoposide, and maintenance of atezolizumab was maintained. These are patients who also had brain metastasis, which was permitted. And then at the endpoints for overall survival and investigated performance PFS. And the key endpoints were objective responses and duration and safety of the drug. Published in 2018 in November, first presented in ESMO. And as we see that there was a median progression-free survival improvement of close to 1.1 months on the MPS, statistically significant at 14 months follow-up. And the median time to overall survival showed a 3 months survival benefit. This became the new standard of care if one would look at it in 2018 after the publication. A warning here. Please remember that this particular article, if one goes into the proper look at subgroup analysis, you would suddenly see that it seems that in males, there is something not working that well. In performance status, 0. Again, we have some issues coming up. Brain metastasis is a questionable benefit there. Surprisingly, for TMB, it seems if you're less than 10 or if you're more than 16, it seems to have an issue. Are we to take this well? This is a subgroup analysis, which is in the supplement of the paper. So I would like you to check it out, although this is an approved indication. We have the CASPIAN data, which is the use of durvalumab. There were 3 arms to this study: durvalumab with etoposide, followed by maintenance durvalumab, cisplatin etoposide 4 to 6 cycles, followed by PCI, or durvalumab with tremelimumab with etoposide and cisplatin, followed by maintenance durvalumab. Endpoint: overall survival. Secondary endpoints: PFS, overall response rate, safety, and PROs. This was important because the PRO, for the first time, was being looked at in a trial in small cell lung cancer, where patient-reported outcomes are going to tell us how did the drug behave, which was important. So we would see that at the overall survival, there is a 13 months benefit, 3 months benefit actually, and this benefit is maintained. I would rather come to the tail of the curve and tell you all that if you're watching carefully at the end of 2 years, you have around 1/5 of patients who are still alive in extensive disease. This was not seen before, while in the control arm, it comes down to something like just 8%. This is just putting it in a different format and telling you what's available and looking at the overall response rates that was there. This was the other standard of first-line care which came up. Comparing both of them in one slide, one would see there's not much to choose when you are comparing both the slides, and they look to be same as we see, including the presentation that came up in ASCO 2020. So first line, till 1985, it was cisplatin etoposide when I started my career. Carboplatin etoposide is what was in between of my career. And now when I'm actually possibly trying to look away from things, as we see immunotherapy in both coming up in the form of eculizumab and durvalumab that has been approved by the FDA. Coming into second line, on June 15th, there was an accelerated approval of a drug called Lurbinectedin. I will come to this drug and talk to you all because this drug actually interests me. We also had at this given point of time the approval of Pembrolizumab for adult patients if the tumor mutational burden was greater than 10 by an FDA-approved test if it was done and if there was no alternate treatment. So that's all the trials, and if you look carefully, we would see that both Pembro and the use of Nibo in second line seem to have an impact. And if you watch, there was also a chance of using it without chemotherapy. So if I look at it in the third line beyond that, and I look at the Pembro or the use of Nibo, the Checkmate 30032 or the Keynote, I would see that responses rates were between 13 to 16% in both the studies. They did reasonably well for a period of almost 5 to 6 months with overall survival. So we have the immunotherapy approved in the third line of these drugs. In fact, we can use the TMB and see whether we can combine 2 immunocheckpoint inhibitors. And if we look at high TMBs, the use of nivolumab and ipilimumab actually gives you a much higher benefit than when you're using single arm nivolumab, or if you're doing it in the lower groups basically. So late online, nivolumab approved for third line, Pembro approved for third line, as we have just saw. So just to fill this gaps in, till 1992, we had single drug irinotecan and docetaxel, although used even by the NCCN was not FDA approved. Topotecan IV was approved in 96. Paclitaxel was approved by NCCN again, but that's not standard of care. Topotecan oral drug in 2007. And now we have suggestions of temozolomide, and of course, as I just showed you, nivolumab and ipilimumab, and we have nivolumab approved in 2018 for third line. What happened at this year's ASCO? Quickly, we go through it quickly and see that Pembro versus placebo in etoposide-cisplatin. This was basically a similar trial of what durvalumab did or what atezolizumab did. And what we do see is that there is a definite progression-free survival and overall survival benefit. So it seems to tell us, although the overall survival was superior in Pembro, statistically not significant, but it seems that Pembro did do reasonably well. And in my opinion, I would feel it does support the use of Pembro upfront. You come down to the nivolumab data, which is similar to the Pembro data, and it can be used. Coming to a drug that Lurbinectedin, which I wanted to talk in small cell lung cancer in second-line setting, this is a first-in-class drug. It's actually a transcription inhibitor, and it prevents a promoter from working, and that prevents actually IL-6 and VEGF working up. We have a success drug in the second line, while the Atlantis trial is there. This is now available for limited approval by the FDA and approved. It binds to the guanine cytosine-rich regulatory areas. It prevents binding of transcription factors and then microenvironmentally changes the drug. New in class, new drug, which is moving very fast. And what does the data look like? If I compare with topotecan, amberubicin, chemotherapy, nivolumab, I would see the response rates are better than even immunotherapy. The median progression-free survival is 3.9 months versus nivolumab. Median survival time is also better, and specifically if it is in sensitive disease. Accelerated approval was made, and the recommended dose is 3.2 milligram per meter square. Coral and basket trials actually proved what I just said, and this is what it is. Yes, there are side effects, but they can be taken. Mainly, please remember, neutropenia and anemia are two major side effects, but they are less than topotecan. Where do we go next? The next thing is we need more therapies to come in. Biomarkers that will tell us where it works best and new agents under consideration. So just to tell you, on your right-hand corner, as you can see, immunology is there with PD-1, PD-L1, CTL4, and CD47. We have the Aurora kinase stuff. We have the DNA repair from the PARP, the epigenetic methods, and the development regular pathway because of its neuroendocrine dysfunctions, which we have is the DLL3 or the Notch pathway. So just to tell you that PARP inhibitors do work, and talazubab has some good data at preclinical level and at clinical level that it can inhibit small cell lung cancer. Same thing holds true for olaparib. I want you to concentrate on the olaparib with temozolomide. There is data telling us it works in heavily pre-treatmented patients, and as we can see that there are patients who did reasonably well. Response rates are around 23% in temozolomide combined with olaparib. Response rate in platinum refractory is 13%. In brain mets, 40% actually respond. Can we tell who's PARP sensitive? We can use a single nucleotide study of doing an SNF11 and get this up. Aurora kinase data is moving in fast, and we know that there are a subset where it works well. In sensitive patients in 55, it gives a good percent, can give a good disease control in refractory in about 50%. Harnessing the neuroendocrine therapy, this is something important because these are basically for the pulmonary neuroendocrine tumors, and they seem to be again doing pretty well. I just wanted to tell you something that tirazaciclib, which is a CDK4/6 inhibitor, has just received its priority review in small cell lung cancer. For the first time, we are now seeing a drug which can actually prevent myelosuppression. In fact, it decreases it by 67%. It decreases neutropenia by 51%. GCSF dose comes down by 80%. So here now we have a new drug that's trying to make chemotherapy more successful. And since we can actually deliver more chemotherapy in this particular situation, we are moving into an area where chemotherapy can be a better effect. So before I end up, let me just tell you two problematic areas which are there, which even the GO2 lung cancer registry tells us if we are using in small cell lung cancer is one, the side effect management. Two, emotional issues. Financial distress and transportation is a major problem. AE side effects are there. I'm sure we are more aware of them. I would always request patients should be a part of our partners in deciding what we do, and that's how we move forward. So I will say, if there is a question and if you have time, I'm ready to take it. Thank you.
Thank you, Dr. Bhattacharya, for that very extensive lecture. And we really look forward to many new drugs getting approval even in small cell lung cancer. Any burning questions? Take one because of paucity of time.
Can I ask GS a question, Jyoti, if you permit?
Yes, sir. Please.
So, GS, very nice talk. Thank you. My question to you is, why is PD-L1 expression not important in choosing an immuno-oncology drug in small cell? And why is it important in non-small cell?
Hemant, in small cell lung cancer, in the upfront when it's combined with chemotherapy, right? It is not being done. But in the second line and third line, it has to be PD-L1 greater than 1%. That's one. In the upfront use with the chemotherapy in small cell is not required, because what we see basically is that they actually chemotherapy acts as an immune sensitizer, which occurs with this. This is something that is a mechanism which we know that all immunotherapy is just not PD-L1 and PD-1. There's much more to it than what we know of right now. So we need a proper answer, but the answer seems that chemotherapy acts synergistically and so enhances the impact of immunotherapy. You can always get back to me and say that maintenance immunotherapy without giving it in the induction never worked, but because you give it in induction, they work together. For second line and third line, you need a 1% PD-L1, at least for Pembro and Nablo.